Hello everyone, my name is Cody Sells. I'm a Master's of Nursing student with Cox College, and today we'll be discussing a case study of a pediatric patient with Croup, otherwise known as laryngotracheal bronchitis. So what exactly is Croup? Croup is the most common middle airway infection that occurs in children ranging from about 6 months of age to 3 years of age. It can occur in children older, but it generally presents with much more mild symptoms. This illness is typically caused by a viral infection, most commonly parainfluenza viruses or RSV, among many others. The patient will generally suffer from this illness in the fall and winter months, and that's just due to the fact that there's increased incidence of viral respiratory infections during those times. Croup will oftentimes present with upper respiratory infection symptoms like cough, congestion, and fever. And then over the next 12 to 48 hours, symptoms just progressively get worse with hoarseness. They may have stridor or the classic barking cough, and that's caused by the narrowing of the airway as a result of edema and inflammation. Symptoms generally improve after 3 days, but they can be present for as long as 7 days. While Croup may be a relatively mild and self-limiting respiratory illness, there's always the possibility of severe respiratory distress and potentially airway obstruction with the disease. In this case study, we have a 3-year-old male patient that presents to the clinic with his mother for a same-day sick visit. The mother reports that the patient has had some sinus congestion and cough for the last couple of days, with symptoms that have just gradually worsened. She says that the patient awoke multiple times in the night last night and has since developed a fever with a max of 101 that has been controlled with Tylenol. Mother reports that the cough has become very harsh and has a somewhat barking quality. Patient continues to take fluids by mouth and have normal urine output, and does not appear to be in any acute respiratory distress upon presentation to the clinic. So in completing a review of systems, it's very important for the practitioner to obtain a thorough history and obtain information from both the mother and the child. In this specific patient, there's no history of any chronic illnesses that could be contributing. The mother reports sinus congestion, the very harsh cough, and fever. There's no reported changes in the skin or the hair, no complaints to the head, eyes, or ears. They do continue to report the sinus congestion, very harsh cough that can be barking in nature at times. There's no swelling or pain to the neck, no tenderness anywhere. There's no changes to the extremities. The mother and child both deny any difficulty breathing, but they do report the barking type cough and just generally sounding very congested when he's trying to breathe, but they deny any whistling sounds with respirations. There's no chest pain, no abdominal pain, no nausea or vomiting, no change in bowel patterns. Patient's urinating normally. There's no difficulty, painful, or increased frequency. There's no neck pain, no back pain, no extremity pain. Patient just generally doesn't feel well. There's no headache or dizziness or no significant change in the patient's behavior. And then lastly, there's no intolerance to heat or cold, and the patient doesn't appear to be flushed. There's no polyuria, polydipsia, or polyphagia. Once the review of systems is completed, the practitioner can move on to their physical assessment of the patient. This patient is conscious and alert. He is oriented appropriately for a child of his age, does have just a general overall ill appearance, decreased activity. He's just laying on the mother's chest. There is an occasional barking cough, croupy cough noted during the examination. There's no acute distress noted. His respirations are even and non-labored. Vital signs are stable with a pulse of 100, regular blood pressure of 92/50, respiratory rate of 22 to 24, temperature of 100.4, pulse ox of 98% on room air. Skin is pink, warm, and dry. He has good skin turgor with no rash or lesion noted. Patient is normal cephalic and atraumatic. Pupils are equal, round, and reactive to light. Tympanic membranes are intact. They are mildly erythematous, but without effusion, exudate, or bulging. Nares are noted to be mildly erythematous as well, with some sinus congestion. Oral mucosa is pink and moist. Throat's also pink. There's no erythema, no swelling, or exudate noted. Neck is supple with no nuchal rigidity or lymphadenopathy. Pulses are palpable, normal to all extremities. Lung sounds are equal and clear bilaterally. There's no stridor, no wheezing, or crackles noted. Respirations are even and non-labored. No retractions or accessory muscle use is noted. Upon cardiac exam, he has a normal S1 and S2 heart sound with no murmur noted. Bowel sounds are present and normal in all four quadrants. It is soft and non-tender. There's no masses or organomegaly noted. Normal circulation, motor, and sensory to all extremities. Again, pulse is palpable. No cyanosis or edema noted. Has good strength to all extremities. Cranial nerves are grossly intact, and the patient moves without difficulty. How is Croup diagnosed? Typically, Croup can be diagnosed just upon clinical presentation and assessment. There's actually no laboratory test that's even necessary, and actually trying to complete some lab tests, including blood draws, can actually exacerbate the patient's condition, causing agitation and anxiety that can increase their respiratory distress and could potentially lead to airway obstruction. Rapid antigen tests such as influenza or RSV may be beneficial if there is an atypical presentation of Croup. And if blood work were to be completed in the atypical presentation, there may leukocytosis would be very uncommon, and this would be suggestive of some other process going on with the patient, potentially epiglottitis, which could be life-threatening. The chest x-ray in the very young is usually sufficient to get the neck as well. Otherwise, a soft tissue neck x-ray can be used to rule out or rule in Croup as well. There's the classical steeple sign that is found in Croup on the neck x-ray, which is caused by the narrowing of the subglottic area. Croup can generally be treated on an outpatient basis and doesn't require any kind of an in-hospital admission or observation. Could be required in some severe cases. It is important to educate the parents on intervention that they can institute in the home setting that can be beneficial to the patient and relieve some symptoms. Things like cool mist, humidity, cool night air have all been shown to be beneficial in alleviating the milder symptoms of Croup, and even including symptoms of stridor. It is important to educate the parent on calming strategy, as increased anxiety and agitation, as previously mentioned, can worsen symptoms and ultimately lead to airway obstruction. The patient should the parent should ensure that the child has an adequate fluid intake. They want to make sure that they avoid any dehydration, as that can also put them at increased risk for needing hospitalization and inpatient management. The patient with Croup would greatly benefit from pharmacological management as well. With fever, antipyretics can aid in relieving their fever as well as assisting with some of the discomfort that they may be in. Dexamethasone is a mainstay treatment of patients that present with Croup, ranging from mild to moderate to even severe Croup. Generally, the dosing is 0.6 milligrams per kilogram, and that's actually just administered in an IM dose one single time in office or in ER. We can do oral prednisolone as well. That's 2 milligrams per kilogram dosing. It's just the alternative, but then that needs to be in divided daily doses, and has been shown to be less effective when compared to the IM dexamethasone. Racemic epinephrine is also another mainstay. It's an option for the patient who presents with respiratory distress. and this option actually provides immediate reduction in the swelling of the airways. But they must be observed for anywhere from 3 to 4 hours following the treatment, because there is significant concern for rebound symptoms, shortness of breath, airway obstruction following the nebulized epi. Worsening symptoms following epi would be an indication for the patient to be hospitalized, and those are things like stridor at rest. And in a more moderate to severe croup, supplemental oxygen may be necessary, and intubation could also even be a possibility in patients who do not seem to be responding to the other treatment options that have been discussed. In this patient specifically that we had presented in the case study, there are very mild symptoms. The patient's not in any acute distress. So in office, we would treat him with just a one-time dose of the dexamethasone, 0.5 milligrams per kilogram in office. And then we would provide a lot of education and instruction to the mother, such as having the child sleep with a cool mist humidifier in the room at his bedside, doing things like Tylenol and Motrin that will help with his fever and his discomfort, making sure he's staying hydrated. And we won't do any additional steroid administration as far as by mouth things with like prednisolone. He's not in any need of any racemic epi. He's not in any acute distress. So otherwise, we'll instruct the parent to follow up in the emergency room should his symptoms worsen. It's not an expected outcome in this patient, but should he experience increased shortness of breath or any respiratory distress, then they would need to immediately follow up in the emergency room. Otherwise, we would just follow up with this patient in office in about a week or so, at which point we would expect complete resolution of their symptoms. So for resolution of symptoms, I think a significant portion of these we have already kind of hit on throughout the previous slides. But dexamethasone has been shown to have a rather rapid onset, and they may have actually improved symptoms within 30 minutes of administration of the IM dosing, and has a very long half-life as well. So we can expect the benefits of those steroids to be in the patient's system for as long as 54 hours following the administration. These effects, the effects of the steroids, often last longer than the actual disease process of croup. So that's the reasoning behind the one-time dosing of IM dexamethasone. As previously discussed, racemic epi is expected to have an immediate effect on the airway swelling. However, there's the need for the required observation following, and then the discussion of potentially in patient monitoring. Oftentimes in mild cases, there's not a significant amount of pharmacological treatment that is necessary. Croup is a very self-limiting disease and should resolve on its own within 3 to 7 days. In the patient that has continuation of symptoms or even worsening of symptoms beyond that 5 to 7 day, the practitioner needs to raise their suspicion for the possibility of a secondary infection, and there needs to be a much more significant further diagnostic workup in order to rule out other causes. Current recommendations for the management of viral croup actually coincide with the treatment plan that we have outlined previously in this case study. They include the utilization of cool mist, rest, antipyretics in the home setting to ensure that the symptom severity is decreased. Patients and their parents should be educated on the potential for airway obstruction and the need for immediate care in the emergency department should the patient experience any respiratory distress or whistling sounds that can be heard when the patient's breathing in. There is an agreement on the use of corticosteroids and racemic epi as a mainstay in the management of the patient with croup. There's minor discrepancies in the dosing of dexamethasone and as to what exactly is most beneficial and effective in treating these patients. There is reports that doses of dexamethasone as low as 0.15 milligrams per kilogram have been effective, but the majority of healthcare providers continue to use these higher doses. And dexamethasone is 6 times more potent than oral solutions, such as prednisolone, and has a much longer half-life. So dexamethasone is truly the standard of treatment in these patients. The treatment plan that we've outlined for this patient follows all of these current recommendations. There's, as I just discussed, no consensus on the utilization of those lower dose steroids, and the dosing should be determined on an individual patient-by-patient basis. It looks like that's all I've got for you. I've got listed here the references that I used throughout this case study and this presentation. Thank you for listening.